Philip Blackman, current president of Engineers and Architects of Hawaii. We invite you to watch our monthly series on Olelo Channel 53. December's Olelo series program is from our November 19th, 2021 Zoom meeting. Our speaker, Dr. George Poore, discusses how prior work on the coronavirus family of viruses in the new mRNA vaccine delivery technique were both critical in the fast development and testing. We encourage your direct participation in this community outreach. So please email us your comments and ideas at eahawaii@gmail.com. Each month, a $50 award will be given for a selected comment or idea on current or past programs.
Okay, everybody can unmute and ask questions for George. I had one question, George. You talked about RNA sequencing, and I think you talked about that, but could you talk a little bit about that? What is RNA sequencing?
Well, it's just getting the three bases code for each amino acid that's part of a protein. And so the sequence of the bases determines which amino acid is where in the protein that's made. So sequencing tells you what protein that part of the mRNA is going to make. So it's basically reading what the mRNA is going to do. DNA in the before Sanger was basically a black box. Nobody knew, everybody knew from the time of Watson and Crick that it was a spiral of bases, but they didn't really understand how it worked. And then once they started to be able to figure out what the sequences did, it's just like what information is conveyed in a book. mRNA, instead of conveying an idea, it conveys a protein. And that's really when you read it, that's what you're trying to figure out, is which protein it codes for.
To what degree is a vaccine strain specific?
That's a hard question. It depends on how closely the proteins in the strain match other strain proteins. The body makes matches to the conformation of the protein. The immunoglobulins get a three-dimensional shape, and they match that protein. If other strains have the same protein, then they'll recognize it really well. If there are mutations in the protein and it's changed a bit, it depends on how much the change is. If the change is to a completely different protein, then there won't be any recognition at all. If it's mostly the same, it may recognize it some and may be somewhat effective against that variant. So it's a hard question. And that's one of the problems with the flu vaccine, is that it always is changing a little bit.
Second question, will there be a test on this material?
I don't know. I'm not sure I could pass it.
I'd like to know if the elephant avoidance serum that you developed, is that effective against Cape buffalo?
It is. It is. I've been using it for a while, and I haven't seen neither elephants nor Cape buffalo. So I think it must be effective.
George?
Yes.
Do you envision, like we do with flu, envisioning needing a booster COVID shot every year or every certain amount of time?
Well, I don't probably, but the flu's kind of a weird thing. The flu, the animal carrier for the flu are birds, and they're everywhere. The carrier for the coronavirus are bats, and the human bat intersection is less. So if we can get the coronavirus under control in the human population, which is a first question, and I'm not sure that's going to happen for a while, but then it may be significantly longer time periods between variants popping up. I mean, it was 2002 to 2012 before there were the first two variants that of the coronavirus that were significant variants that came out of the bat population or whatever the repository is. So I don't know. I think it's going to be less frequently mutating than flu. Also, one interesting thing about coronavirus is one of the few RNA viruses that has its own error checking system. If you look at the Ebola virus, it mutates at about 1,000 times the rate of coronavirus. The mutation rate is lower. Right now, there's so much virus in the human population that you're going to see a lot of mutations just because of the huge numbers of virus out there. But I think that once it's under control, it will happen less often. Of course, it's like predicting the weather, everybody forgets the prediction in 2 days and you don't remember what the prediction was anyway. So it doesn't matter if I'm right or wrong, but that's my prediction.
Thank you.
Hey, George, do you feel that this virus was man-made or manipulated by man, like a bat virus that was manipulated in some way?
I don't really have any way of knowing that. I think that it's much more likely that it was in the bat population, just because there are billions and billions and billions of more virus in bats than there are in labs, and mutations are related to the number of potential viruses there are to mutate, and most diseases do just fine without human intervention. They manage to figure out a way to infect humans anyway. But since we're not able to look at the Chinese situation because the Chinese are not letting anybody look at it, it's hard to know. I mean, I can't tell you. It could be that it was a strain that they had and got out, or it could be, I think it's more likely that it was a zoonotic disease that spread to humans.
Do you happen to have any information that would compare natural immunity with immunity from the vaccine for the COVID-19? I hear a lot of talk about, well, if you've had the disease, you really don't need the vaccine.
There are papers that say that conflict with each other. The vaccine causes a very specific immunity to a very specific protein. If you get the virus, you may actually you may learn to recognize a different protein, and some of those don't work as well. There are studies in the last few months that say that you're better off getting better off getting the vaccine, because people who've had the vaccine are less likely to get a second infection than people who've been infected first. And that is a pretty large study. There are also studies that suggest the opposite. They are smaller studies, and I don't know which is real. Either way, you should get pretty good immunity against the virus.
And what about the vaccines for these young children? Since the rate of infection is so low in that population.
Yeah, that's true, but there are children that die from the disease. I mean, it's in the hundreds, not tens of thousands. And one of the things that's hardest is you don't know what the long-term side effect of this is going to be.
Right.
There are a lot of autoimmune diseases that happen later on that probably were the result of an infection that happened before. and we just don't know. My view is that the more humans we have vaccinated, the sooner the disease will come under control, and the sooner we'll be able to get back to seeing people and being humans again. And that includes kids.
Hey, George.
Yes.
Hey, one of my colleagues claims that if you receive natural immunity, that within 4 to 5 months, you may have lost that immunity. Any validity to that claim?
By natural immunity, he means having had the disease.
Have the virus, yes.
Well, it seems to diminish over time whether you had the vaccine or had the disease. And I mean, that happens. One of the reasons that you catch colds year after year is because you develop immunity, but then your immune system sort of forgets, and then you get a little bit of a change and you're able to catch another cold. So, and this does seem to go away after one of the reasons that boosters have been approved is because your immune response diminishes. You get a lesser response 6 months after the vaccination than you do 2 weeks after the vaccination. And the same is true for people who've had the virus. They also lose immunity to some extent.
On your graph that showed that 15% more people died than normal,
Right.
And it was compared to people that had died in years gone by. Now,
Right.
What were those people dying of? And did they stop? I know you mentioned the flu, but were they falling off rooftops or?
Yes, I mean that's everybody dying from every cause. That's heart disease and cancer and trauma, and those are all of the deaths. President Trump said there are only 6% of people that are dying with COVID. If you looked at the data, what he was saying is were 6% of people who died where their only diagnosis was COVID. Most people when they die have some heart disease, and they may have some other emphysema or some other diseases. And he was discounting all of those. Those were people who had only COVID as a diagnosis when they died. What people were saying was that, well, when somebody dies and they have COVID and they've got 5 other things, that those people would have died anyway, and they just stick COVID on as the cause of death. And the only way you can really tell how much of a factor that is you look at everybody who's died from every reason, and then you compare it to year by year, because the chances are pretty good that what people died of last year are the same as what they died of this year, with the exception of what you're looking at, in this case, COVID.
Are there any publications on the side effects of taking the vaccine?
Yeah, there are. And I mean, it's really, the vaccine, as you've heard ad nauseum, is safe and effective. There are people who've died from the vaccine. My son, who just finished lab science at Dartmouth for his fellowship, thinks there are probably about 5 people who've actually died from the vaccine itself. The website lists about 2,000 people, as compared with whatever the actual number in the US is, 700,000 or whatever. The myocarditis thing is probably an issue, but it's rare, and it's not nearly as common as it is if you get the virus. If you get the virus, myocarditis is not a rare thing to get. It's a very rare thing to get if you get the vaccine. One of the problems is that the way that the data is stored, the government says, well, if you have any problem after the vaccine, we want to know about it. And they store all of that, and it's all publicly available. And my son was saying, yeah, that if you look on the government website, and you can see that there were 5 people that died, the headline will read, "Vaccine causes multiple deaths." That's true, but it's also misleading. So given that there are millions and millions of doses given.
Thank you.
Hey, George, did you hear anything about the government that wants the employees of organizations vaccinated that are more than 100, that the government told them, we don't want to hear about any adverse side effects? Did you hear anything about that?
No, I didn't, and I'm not sure I believe it. That wouldn't make any sense. Why would they do that?
I don't
mean,
know.
they-
It seems like people kind of mistrust the vaccine because there have been more reactions than have been reported.
That's probably true. I mean, but it's also true that the mechanism for reporting is very sensitive, and I think most vaccine reactions are reported, and I think that they're also, basically with a pandemic like this, you're either going to get the vaccine or you're going to get the virus. I mean, it's just a matter of time, and it's definitely thousands of times safer to get the vaccine than it is to get the virus. So as a surgeon, I always had to talk to people about, the risk benefit, and there's a risk with either one, but the risk getting the virus is significantly greater than the risk of getting the vaccine.
Yeah, that's one of the things that I find strange is that they're more willing to take a remedy from their neighbor that has no medical training and heard a rumor from his best friend's girlfriend's brother's sister that this happened, and I better take that. So
I've got my cow urine right here.
yeah. So okay.
Hey, George. Oh, can
Yes.
I not? Okay. Are there any treatments, or is natural just letting the virus play out the normal way to combat this thing?
No, there are some treatments now. I mean, the convalescent serum actually turns out not to be quite as good as they thought. It was just a paper that showed that it didn't benefit as much as people thought. But you can get passive immunity through antibody treatments. They've been able to make antibodies that you can get, and those do reduce the risk of dying and of being hospitalized. Not as much as vaccines, but they do reduce the risk. And it's the same for there are two brand new antivirals that are being introduced by Pfizer, and I don't know which the other company is, but the Pfizer looks like it's in the same ballpark as a vaccine. It's 80% effective at reducing the risk of hospitalization and death. It's not 95% like the vaccine is to start with. But yeah, there are some that are being developed, and those are probably going to be reasonable things to consider.
George, do we have any data being collected on breakthrough cases, those that have had the vaccine but yet still do get the virus?
There are people who've had the vaccine that get the virus. That the chances, though, as those slides show, you're about 6 times more likely to get the virus if you've not had the vaccine, and you're about 11 times more likely to die. And those numbers are still holding true. Is there a risk that you can get it when you have the vaccine? Yeah, there is. But you're less likely to have a problem than if you've not had the vaccine.
Thank you.
So Novavax is on the horizon, and it's not an mRNA.
Right.
And with respect to people who are autoimmune compromised, they have an extra sensitivity to what goes in their body to try to fight off stuff, and how their body's going to react. So, and then I just wanted to wrap this all just to shut up, is that when this all started, we didn't need masks, and that was because we wanted masks for healthcare workers. So the government always has to weigh, telling the public the absolute truth at the risk of panic buying versus, protecting the overall good of the population. So that
Right.
started us off on the wrong foot. And it's a tough battle to get back to trust somebody who does that. So.
Right. And as you pointed out, I mean, originally there just weren't enough of the N95 masks. And the people who needed them were the nurses and docs that were dealing with the COVID. If everybody was wearing those masks, then nobody who really was on the front line would have them. And that did result in some misunderstanding and misinformation, I think, which was too bad. I use N95 masks now. They're the only ones that actually, as a surgeon, the studies showed for years that you weren't protected. Yeah, the surgeon themselves wasn't very protected, but your patient was. The chances of stuff ending up in an open abdomen were smaller if you were wearing a mask.
So the autoimmune versus mRNA versus Novavax is an interesting subject to me. And there's a lot of concern among the autoimmune compromised. And there was research in this field, but it's always skeptical because Western medicine hasn't always treated those folks, with the
Right.
best.
One of the nice things about the mRNA vaccines is that they don't, it's not an infection. Whereas if you use the attenuated vaccines and you don't battle a virus very well, there's a chance that you can get a mutation and actually get the infection. And so for people who are immune compromised, the RNA vaccines are really a game changer that way. The protein vaccines, I went through this a little bit. Protein vaccines don't carry a risk of infection either, but they also don't work very well. There may be successful DNA vaccines, but they're really hard to get into the nucleus. They have all of these. Basically, they use electrical shocks to put holes in the nucleus to be able to get the DNA in there, and it just and there are vaccines that are trying to do that. The RNA is really a game changer. It gets a non-infective protein maker into your cell, and your cell. People say, "Oh, there's a risk of getting into the DNA." Well, there's really the way that the cell works. There's really no reasonable way to get an RNA into a DNA. It just doesn't happen. There are viruses that do that. You have to have special enzymes and special prophages that use RNA, and they reverse transcriptases and all that stuff. But this doesn't have any of that. The RNA vaccines are by far the best that people with immune compromise have ever had. You get all of the benefits and really none of the downside.
Thank you.
Hey, George, what's your thoughts on ivermectin?
It's been pretty well studied. Both ivermectin and chloroquine. If you take them and look at mouse cells, and you infect the mouse cells with COVID, and you bathe the mouse cells with either ivermectin or chloroquine, then the virus is inhibited. The problem is that's never been shown to be true in humans. I mean, then there are lots of things that work in mice that don't work in humans. There have been studies, and there are no studies that I know of that are any good. I mean, there are people that say, "Oh yeah, I drank the cow urine and it worked just fine for me." There are no studies that are any good that show either one of them makes any difference.
Gotcha.
And both of them have a small risk. And if it has no benefit and it still has a risk, then it's probably not a good thing to take.
Yeah, the previous owner passed away from COVID, but he lived in Texas at the time.
Right.
And he was just pretty staunch on the ivermectin, and he was, hey, you guys better start taking some. And I was like, I was like, I'm not quite sure yet, but okay. But he said when he caught COVID, he had a few days where, you know, he was trying to get some, and all the doctors, they didn't have any because they had prescribed it all out. So
Right.
it was a
Right.
very,
Yeah. If I were, I'm retired, but if I were prescribing, I would not prescribe it. It's,
gotcha.
yeah.
You know, going back to 15% more people have died in the US than died last year of
Right.
disease. What is the world situation? You know, it seems like when I see numbers, they're in the millions. And are these people that is that the same situation? They compared somehow to normal diseases that they would have had anyway.
Yeah. And I don't have the numbers for the world in front of me, but the Economist published an article on what they think the world mortality is. And they think the world mortality is closer to 20 million. And using the same sort of analysis. The problem is that you don't really know if somebody dies. One of the problems with, and one of the advantages of using the excess mortality, if somebody dies in Bangladesh, they don't get tested for COVID. It's just not something that happens. And so there's a lot of mortality that they may not have died of COVID, or they may have died of COVID, and you just don't know. And so the excess mortality data is the only way to really look at that and figure out who died. That's really where the numbers for the 1918 flu come from. It's really excess mortality that was looked at to decide, how many people died of the 1918 flu. Was it 40 million? Like was 30 or 40 million were the initial published figures, but a lot of people think that it was closer to 100 million, just because of if you look back and look at the deaths that happened before and after, that bump stands out as much bigger than people thought it was.
The 20 million figure, would you say that's 15% more than the people would have died or dying or died the year before or something?
Well, the 20 million figure is for the world, and I don't have the baselines for the world and I don't think and I don't think much of anybody does. Probably, mostly that data is hard to collect. It takes probably a couple of years for death records to be examined, and not all of it's, especially in developing countries, not all of it's computerized, and it's so I don't know. I don't have any really good way of looking at that. The Economist article made a lot of assumptions which may or may not be true about excess deaths, and the 20 million may be totally bogus, but that's what their assumption was.
One more question then. When those diseases like AIDS and SARS were in Africa, it was like those people had not been dying of those diseases, and we were right on top of it, right? Is that something like that happening with COVID too?
Well, those people were dying. When I was in New York, we were in the early 80s, before we knew what AIDS was. We were seeing people coming in with Kaposi sarcoma, which is one of the ways that people with AIDS die. We would see, before the early 80s, they would see 1 or 2 cases a year of Kaposi sarcoma. And we were seeing dozens of people a week coming from Africa with this disease. So there were lots of people dying of AIDS before people knew there was AIDS that they were dying from. I'm not sure I understand your question, I guess.
No, I think that's a good answer. Thank you.
I guess on that same line, we're able to contain Ebola, and that seemed like a really deadly disease, and we were able to contain it, so to speak, by our normal, if you want to call it that, ways of containing a virus, which is, containing people and limiting access to it. That seemed to be effective for that disease. But this disease, COVID-19, just blew through everything and went around the world in months.
There's a couple of really significant differences. One is that the biggest difference is that the people with COVID have it for several days before they even know they have it, and they spread it before they even know they have it. Whereas somebody with Ebola, they get bleeding, they're vomiting blood, they're dying, and it's also not a respiratory virus. It's only by contact. So people go around with coronavirus, can go into a closed space and infect, 5 or 10 people and not even know that they have it, and the people don't know that they have it. And then the same happens. And so, and it's very infectious. It's not quite as infectious as measles, but it's a very infectious virus. And so that's the biggest difference, is that people with Ebola don't spread it because they're dead. I mean, the mortality from Ebola is 80% or so, or maybe even higher than that. So they're not out wandering around the streets spreading it. But people with COVID, they don't know they have it, and so they go around and spread it for a while before they even get sick.
Yeah, I think I had heard something like that as to why diseases between species do not happen that often. And one reason is that if there is one disease that gets through, it's usually very deadly and it kills a small number of people, and then that stops the spread, which I guess is maybe with Ebola, which is kind of what's happening with Ebola.
Well, and with the MERS epidemic, that was sort of the same thing. It wasn't as infectious, but the mortality was 35%, but there were only 2,500 people that ended up with it, mostly because the people who got it were really sick and died and didn't spread it.
Yeah.
Do you think anybody should be, other than religious exemptions, anybody should be exempted? And the big example is people with autoimmune disease.
I think people with autoimmune disease are the people who should get it the most, because you don't know what your response to the vaccine is going to be. Now, are you talking about people with diseases?
One example would be Crohn's disease, for example.
Right. Well, I mean, unless you have an immune suppression, if you're taking something to suppress the Crohn's, then you're more likely to get sick from the virus, and it's worth taking the vaccine for that reason. If you're not taking the medicine, it's probably a comorbidity, and you're probably a little bit more likely to die from the virus, just because you have one additional thing. And the virus does infect people. It does. Some of the ACE receptors are present in the gut, and people with COVID do have gut symptoms and can have gut problems sometimes. And I do not know how that translates to Crohn's or not. So I don't really have a good answer for your question, other than, if you're really sick from another disease and you get a second disease, then it can be harder on you. Or if you're taking immune suppressants to suppress the Crohn's, that's a different world, and you should get a vaccine.
So a fully vaccinated individual, if they take Pfizer, requires 2 doses. And
Right.
that gets them to 90%, correct? Or something like that?
Yeah, 95%. Right.
95%, okay. Correct me if I'm wrong, the first dose will get you to about, like 80%?
No, 30%.
Oh, 30%, okay.
Right.
All right, no, that answers the question then.
Okay. Yeah.
All right.
Okay, George,
Okay.
appreciate it. Everybody
Thank
can,
you all for suffering through this.
Oh, no, it was very
Thank you very much,
informative.
George.
So with that, we can close the meeting, and we'll see you guys in 2 weeks. And George, I
Thank
really
you all for
appreciate
having
it.
me. Yep, you bet. Okay.
Yeah, thank you,
George.
George, very much.
Appreciate it.
You
All right.
betcha.
Okay,
Jeff,
good to
nice to
see
see
you.
you. All right.
bye.
See you, everybody.
Okay.
Take care.
Engineers and architects of Hawaii welcome your comments on this program and any of our recent programs. We encourage your direct participation in this community outreach. So please email us your comments and ideas at eahawaii@gmail.com. Each month, a $50 reward will be given for a selected comment or idea on current or past programs. Mahalo.